This lecture is about diabetes and pregnancy. Diabetes in pregnancy could be a pre-existing diabetes or gestational diabetes. The pre-existing diabetes classified to type 1 and type 2 diabetes, while the gestational diabetes could be a pre-existing one or a true gestational diabetes, which means gestational diabetes which is discovered during pregnancy for the first time. The effect of pregnancy in pre-existing diabetes: it increases the requirement for insulin. If you have nephropathy, neuropathy, it may deteriorate. The progress to diabetic retinopathy is doubled. It might cause hypoglycemia and diabetic ketoacidosis. The effect of pre-existing diabetes on pregnancy: it has two arms. One arm is the effect of diabetes on the mother and the other on the fetus. The effects on the mother: it increases the insulin requirement. It might cause hypoglycemia, infection like candidiasis, UTIs, ketoacidosis, deterioration of retinopathy, increased proteinuria and edema, miscarriage, polyhydramnios, shoulder dystocia, preeclampsia, and increase the incidence of cesarean section rate. On the fetus, it increased the incidence of congenital abnormality, increased neonatal and perinatal mortality, macrosomia, intrauterine death, hypoglycemia, polycythemia, and jaundice. And that's why it's important to know how to deal with pregnancy to reduce all these effects. Now, how these effects happen with the diabetes. Now, the maternal if there is maternal hyperglycemia, then obviously there will be a fetal hyperglycemia because the fetus is getting his nutrition from the mother. So whatever come with the blood of the mother, the fetus will have it. If the mother has hyperglycemia, then the fetus will have hyperglycemia. Now, the fetal hyperglycemia will stimulate the pancreatic beta cells of the fetus, and it will cause hyperplasia. Hyperplasia means more production of insulin in the fetal circulation. Now, this will cause fetal hyperinsulinemia. As we know, the insulin is anabolic hormone. This will cause macrosomia, organomegaly, polycythemia, hypoglycemia, and RTS. The aim of the management is to control the hyperglycemia, which is responsible for everything. So the idea is to have a normal glycemic level to prevent any complication. How we do that? We start first with diet, with low carbohydrate diet, high fiber with caloric restrictions, frequent small snacks may be needed between meals, and we should avoid starvation. If this doesn't control the situation, then we move to insulin. And the ideal dose of insulin is pre-meal short-acting insulin, the fast-acting insulin. We might use also intermediate-acting insulin to allow maximum flexibility and control overnight. The target blood sugar is fasting less than 5 and 2 postprandial less than 7 millimole per liter. Can we use our hypoglycemic agents? In the past, it was believed that all the oral hypoglycemic agents will cause teratogenicity, and we avoided them. Now, new research on metformin showed that we can use it safely in pregnancy. So we used to stop them all and shift to insulin all diabetic patients. So if they are diabetic and discover that they get pregnant, we stop whatever they are taking, and we start them on insulin. But after discovery that the metformin, which we used to treat polycystic ovarian syndrome, can be used during pregnancy without any problem, we could use metformin, but not the other type of oral hypoglycemic agent like sulfonylureas. Now, the metformin is a category B drug, so there's no evidence that affects the baby in pregnancy. It's not teratogenic. It reduces the first trimester miscarriage, and it reduces the incidence of gestational diabetes by 10 times. These are the drug categories. Now the sulfonylureas, on the other hand, they are category C, so we try to avoid them during pregnancy. Insulin, the rapid-acting insulin is safe to use during pregnancy and it's classified as category B. The long-acting insulin categorized as category C, so it's better to avoid it. How we monitor the diabetic patients? First of all, we want to monitor the glucose by home glucose test. We can also monitor by checking the glycosylated hemoglobin, which gives us an idea about the control over the last 3 months. Regarding the baby, we have to monitor the growth. As we said, the insulin will cause overgrowth of the baby and macrosomia, so fetal growth monitoring is mandatory. Also, we need to refer patient for ophthalmologist to check the retina. Delivery, we should individualize the delivery, but we should time it and plan it before. If everything is normal without any complication, we induce the pregnancy or we induce delivery at term. When the patient comes to the hospital, we start what we call sliding scale, which means she stop any doses of insulin in the morning. We check the fasting blood sugar and we check blood sugar every hour. And according to the result, we give insulin. So we have the insulin or the glucose controlled all through labor. There's no contraindication for breastfeeding, either with insulin or hypoglycemic agent. So the diabetic mother immediately after delivery, even the gestational diabetes, the diabetic mother, after delivery, immediately we shift them to their pre-pregnancy medication. And this doesn't affect, as we said, breastfeeding. Now, ideally, all diabetic mothers should have a preconception counseling. The idea of that is to enter the pregnancy with optimum diabetic control, because all the complications are less if the glucose is well controlled. Also, if the patient have any complication of diabetes like hypertension, nephropathy, retinopathy, should be controlled before we start pregnancy. If we check the glycosylated hemoglobin, the lower the glycosylated hemoglobin, the less chances of congenital abnormality, and the better is the outcome of pregnancy. If we have proliferative retinopathy, we might treat it before the conception. If we have one of these conditions, it's contraindication to start pregnancy. These conditions are ischemic heart disease, untreated proliferative retinopathy, and severe renal impairment with creatinine more than 250 millimole per liter. Now the other entity is the gestational diabetes. It is defined as carbohydrate intolerance discovered for the first time during pregnancy. This also includes about 30% of pre-existing diabetes. So there is 30% of the gestational diabetes is due to pre-existing diabetes, which was unrecognized before. There's some debatable issue regarding gestational diabetes, which include is the safety. How safe is it to screen all patients? Also, there was a debate about the treatment, the effectiveness of treatments on both mother and baby. However, research showed that there is benefit of treating gestational diabetes. So the recommendation is to treat gestational diabetes. Now, screening for gestational diabetes. As we said, gestational diabetes is discovered during pregnancy. It's usually occurred in the second half of pregnancy. So the best time to screen for it is between 24 and 28 weeks. Because at this point, the gestation, the diabetogenic effect of pregnancy is manifested in this period, during this period, and from this period until delivery, until 40 weeks, we have enough time to control the situation to avoid complication. So the best time to screen is between 24 and 28 weeks. Now, do we screen everybody? This is one of the debatable issue about gestational diabetes. We don't screen between 24 and 28 weeks everybody, but we screen at the beginning of pregnancy everybody. Now, at the beginning of pregnancy and mainly at the dating scan, we screen by fasting blood sugar or random blood sugar. If this is normal, then we don't need to screen anymore if there is no other risk factors. If this is abnormal, then we need to screen with glucose tolerance test. Now, if the first screening at the dating scan is normal, and you have one of these risk factors, which is age more than 25, BMI more than 25, previous gestational diabetes, family history of gestational diabetes in first degree relative, like on the mother or the father, previous big babies more than 4 kilograms, previous stillbirth, polyhydramnios, big baby in this pregnancy. If you have one of these, then you can screen with glucose tolerance test between 24 and 28 weeks. The way we screen is by 75-gram glucose tolerance test. And we do this, as we said, between 24 and 28. If the fasting between 6.1 and 6.9, this is impaired fasting glucose. If the fasting is 7 or less, and the postprandial between 7.8 and 11, this is impaired glucose tolerance. If we have very high blood sugar, fasting more than 7, or postprandial 2 hours later more than 11, this is frank diabetes. As we said, the first screening by fasting, random. You can use glucose challenge test, but it's easier to use fasting or random blood sugar. And the diagnosis is by 75-gram glucose challenge test. The incidence of gestational diabetes is up to 9%. It's more common in Asian and Indian women. In the developed world, it's becoming more common because of increase of obesity. The clinical significance is the same as diabetes. There's high incidence of macrosomia and adverse pregnancy outcome, the same as pre-existing diabetes. As we said, 30% of identified gestational diabetes, in fact, they are unrecognized pre-existing diabetes. Now, this slide just explain to you that the glucose control is very important. The worst is the glucose control, the more chance that you have congenital abnormalities and neonatal complication. The fetal complication, again, is the same as fetal complication in diabetic or pre-existing diabetes. Macrosomia, weight more than 4 kilogram, up to 30% of that compared to 10% of control group. Increase of instrumental delivery and cesarean section, forceps, vacuum, birth trauma such as Erb's palsy, brachial plexus injury, and fracture of the clavicle. Increase the incidence of neonatal hypoglycemia, hypolipidemia, and polycythemia. The hypoglycemia is due to the fact that after delivery, suddenly the glucose level reduced, but the baby was used to produce more insulin. This will cause hypoglycemia. That's why it's important to monitor the baby for hypoglycemia. Children are also at risk of type 2 diabetes and obesity in life, the same as mother. Maternal complication, increased risk of preeclampsia and hypertensive disorder, instrumental delivery and cesarean section rate, and there is 4 to 60% chance that the mother will develop later on life the type 2 diabetes. This is one of the most debatable issue in the past about diabetes is there any benefit of treatment, but the recent evidence showed that there is evidence of treatment. The HAPO trial, it's reported also there's evidence of benefit of treatment. The management generally is the same as pre-existing diabetes. Basically, try to control glucose. The more control you have, the less problem you will get. Monitor glucose, start with diet, then move to insulin if you can't control it with diet. And put a clear plan for delivery, depends on individuals' circumstances. Now, because there is risk of developing type 2 diabetes, it's better to advise the woman to screen annually for diabetes. Conclusion, gestational diabetes, there's many issues debatable, but the end result is it's better to treat gestational diabetes. The morbidity increase as glucose level approach the diagnosis of diabetes, which means the higher the glucose level, the more likely you'll have complication. Treatment possibly improve outcomes. There's overlap with pre-existing diabetes, especially type 2, and this is about 30% of the chances of the cases. Long-term application for health of the mother and the baby, developing basically type 2 diabetes. Thank you.